लगा सकते हो।
नहीं तो बच्चे कैसे इसको लॉग इन करते हैं?
ऑनलाइन मैम, तो अपना LT का लिंक दिया, तीनों LT को लगा।
नहीं तो वो कभी भी लिंक कर सकते हैं कि अभी करेंगे, बाद में उनको अगर सपोज अभी किसी ने अटेंड नहीं किया
हाँ जी,
तो बाद में कर सकते हैं।
ये 16 घंटे बाद का है मैम इसका रिकॉर्डिंग का कुछ।
हेलो, हाँ बताओ। हाँ मनोज बोलो। नहीं मैं क्लास में हूँ, स्टार्टिंग अ क्लास इन 5 मिनट्स, ठीक है। 4 बजे तक, 4 बजे तक क्लास है, 2 to 4 मिनट्स, ठीक है। शुड बी फिनिश बाय 3:30। नहीं तो 4 अभी लाइव होगा। अच्छा पर उसके बाद मिल जाएगा उनको। नहीं तो 4 अभी लाइव होगा। अच्छा पर उसके बाद मिल जाएगा उनको। नहीं तो 4 अभी लाइव होगा। अच्छा पर उसके बाद मिल जाएगा। चालू क्यों रख दिया आपने?
नहीं वो ऐसा कुछ नहीं होता। बाकी आ रहे हैं सर आएंगे?
पता नहीं, डॉक्टर अदिति तो आएंगे, और डेंडा तो पता नहीं।
आप कर सकते हैं शुरू से,
मैं कर दूंगी
जब करना बता दें, मैं इसको लगा दूंगा।
हाँ, एक सेकंड कुछ दूंगी। इसको खुद कहाँ से रहा है? यहीं से खोल लेती हूँ ना।
लगा दें सर।
Good afternoon everyone. So we are going to be talking about nephrotic syndrome today. Nephrotic syndrome is a fairly common group of disorders which we see in an adult nephrology clinic. So what is it? How do we define nephrotic syndrome? It's basically a constellation of symptoms. A patient presents with swelling or edema, as you see, facial puffiness and swelling over the legs. On investigation, the patient has protein in urine. The quantity of protein is important. He should be passing around at least 3 to 3.5 grams of protein per day. The serum albumin should be lower than 3 grams per deciliter, and there is a associated abnormality in the lipid metabolism. So there is a dyslipidemia. So when we talk of nephrotic syndrome, it is not a single disease entity per se. It's a syndrome, and it has multiple etiologies. So we're going to talk about the etiologies, why swelling develops in these patients, what are the other clinical presentations and complications, how do we diagnose these patients, and a little bit about the common causes of nephrotic syndrome in adults and how we treat them. So when we are talking of etiology, why does protein leak in urine starts? The protein leak in urine can be due to multiple causes. Basically, if you look at the kidneys, they have multiple units called nephrons. So each nephron has this bunch of glomerular capillaries, and the blood passes through these capillaries, and the excess water, salts, electrolytes, everything gets filtered out into this Bowman space into the renal tubules, and finally it passes out as urine. So the glomerular capillaries have a sort of a filter. They serve sort of a filter, and their wall is composed of the endothelium, the glomerular basement membrane, and on the outer side there are these specialized epithelial cells which are called the podocytes. The podocytes have these food processes, and these food processes interdigitate with each other. They're separated by these slit diaphragms. So any abnormality at any level of this filter, whether it's in the endothelium, the basement membrane, or these podocytes and the slit diaphragms, will lead to an abnormality in the filter. And when the filter gets damaged, it allows protein leak into the urine, which is normally not seen. So why does this glomerular damage occur in nephrotic syndrome? Most of the causes of nephrotic syndrome, predominant cause of glomerular damage is immune mediated inflammation and injury to the components of the filter. Sometimes the immune mediated inflammation, the insult is known and identified, sometimes it is not identified. The other causes, genetic mutations affecting the proteins which are components of the filtration barrier. This is somehow more common in children, of course, than in adults. Other causes of proteinuria, which may or may not be to the extent leading to a nephrotic syndrome, can be seen in systemic metabolic diseases like diabetes, where there is thickening of the glomerular basement membrane due to long-standing effects of hyperglycemia, or deposition diseases like the paraproteinemias and amyloidosis, where abnormal proteins get deposited in the renal tissue. So when we talk diseases causing glomerular damage, they are classified as primary and secondary. Primary means limited to the kidneys, and secondary is a systemic disease which also affects the kidneys. Now, when we talk of nephrotic syndrome per se, the most commonly we are talking about primary glomerular diseases. And among the primary glomerular diseases, the three main causes are minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Now we need to understand that these three diseases, when we are talking about, they are more disease patterns which are seen on histopathology, which will be discussed further by my pathology colleague. But there can be causes for this disease pattern. It can be idiopathic or primary minimal change disease, primary FSGS, or primary membranous nephropathy, which usually means that the cause is not known or the cause is presumed to be immune mediated. And it can be secondary, which has wherein the underlying cause is usually recognized, or there is a systemic disease causing this abnormality. Now among the adults, if we look at it, if you look at data from our country, the commonest causes are minimal change, FSGS, and membranous nephropathy. Though IgA nephropathy is the commonest primary glomerular disease in adults, it may not always present as nephrotic syndrome, while minimal change, FSGS, and membranous, usually the commonest presentation is a nephrotic syndrome. Now, when we are looking at these three, when a patient presents with nephrotic syndrome and a kidney biopsy shows any of these patterns, we should not presume that it is a primary. We should think that there should be maybe an underlying etiology. As I said, idiopathic is what we usually refer to as primary glomerular diseases, but there can be drugs, infections, and malignancies which can lead to a glomerular disease pattern which causes nephrotic syndrome, and we should always look for this because it has therapeutic and prognostic implications. Now coming to secondary glomerular diseases, secondary glomerular diseases form 30% of the cases of nephrotic syndrome we see in a renal clinic, and this is where adults vary a little bit from children. So first thing, in adults, as we said, primary glomerular disease, membranous nephropathy, FSGS, and MCD are common, but they are equally distributed. So we cannot say that one predominates over the other, and we cannot presume unless we do a kidney biopsy. Secondly, secondary glomerular diseases are more common in adults compared to children. Commonest causes are autoimmune diseases, especially lupus, metabolic diseases like diabetes, deposition diseases like paraproteinemias like multiple myeloma or amyloidosis, or other familial diseases. Now we should remember that secondary glomerular diseases sometimes cause heavy proteinuria but may not always cause a nephrotic syndrome. So we should know how to differentiate nephrotic range proteinuria versus nephrotic syndrome. So if a patient has significant proteinuria like 3 to 3.5 grams, but does not have a low serum albumin, or does not have significant edema, or does not have a high cholesterol, clinically or histologically there are certain things which point out to a prime nephrotic syndrome, then it is not taken as a nephrotic syndrome, it is taken as a nephrotic range proteinuria. Now, why is this low serum albumin in these patients? Hypoalbuminemia is caused by, obviously, if you are losing more protein in urine, there is increased urinary filtration of protein, so the protein content in the body decreases. This filtered protein is catabolized in the renal tubules. The liver tries to compensate for it, but it is not able to compensate adequately for the urinary loss of albumin. Now, how does edema develop in these patients? So, there are multiple factors at the capillary level which pushes fluid out into the interstitial space. There is a decrease in the plasma oncotic pressure, obviously because of low serum albumins. There is increase in the capillary hydrostatic pressure, which I'll come to later. Because the fluid and protein are being pushed out because of increased capillary permeability, there is increased interstitial oncotic pressure. So because of this, the net movement of fluid, as you see, is from the capillary bed to the interstitial space, leading to edema. So there are two famous hypotheses, as you call, for nephrotic edema. One is the underfill hypothesis and the other is the overfill. So what is underfill hypothesis? Basically it says that the problem starts with the low serum albumin, as we discussed how it happens, which causes a decrease in the plasma oncotic pressure that causes increased capillary filtration, leading to edema. The increased capillary filtration causes contraction of the plasma volume. So when the plasma volume contracts, a physiological response is that it activates the renin-angiotensin system, leading to increased sodium retention in the kidneys, which expands the extracellular fluid volume, that further dilutes the albumin levels and relatively decreases the serum albumin, and so it's a vicious cycle leading to edema. Multiple factors are involved in causing renal sodium retention, as I said: activation of the renin-angiotensin system, increased levels of vasopressin, and lower levels of the atrial natriuretic peptide. But there's also a theory that in nephrotic syndrome, there's a primary abnormality in the kidneys rather than the secondary activation of sodium retention. So there is a renal tubular abnormality which promotes sodium retention, which expands the extracellular volume irrespective of the albumin status and causes edema. It's now recognized that there's a bit of overfill and underfill. Both the hypotheses act in concert to cause nephrotic edema. Why does primary renal sodium retention occur? The sympathetic nervous system is activated in nephrotic syndrome patients, and this leads to increased efferent and afferent arteriolar constriction, leading to increased resistance. This causes increase in the glomerular capillary filtration pressure. This increased sympathetic nervous system activity causes activation of the tubular receptors, which leads to sodium and water reabsorption throughout the nephron. There is also a resistance to atrial natriuretic peptides. There is activation of epithelial sodium channels and increased activity of sodium potassium ATPase, which promotes the absorption of sodium in the distal tubules. Now, having looked at why the low serum albumin and edema happens, so how does the patient present? As we saw in our first slide, there is progressive lower extremity edema, there is periorbital edema. Fluid can also accumulate in the serous cavities, leading to ascites, pleural and pericardial effusions. Chronic low serum albumin and persistent proteinuria causes fatigue. This frothy urine, patients, this is often patients will tell you in a leading question, they have frothy urine because the albumin reacts with the air, causing froth. And next comes complications. So some complications are serious in a nephrotic syndrome. One of them is thromboembolism. So you know that your protein is lost in urine, and it's not only albumin. Many coagulation factors are also lost. So there is an imbalance with an increased levels of procoagulants and lower levels of coagulation inhibitors. There's also thrombocytosis in these patients because of the chronic inflammation. And all these things leads to a hypercoagulable state. It is more common with very low serum albumin levels, and it is particularly more common in patients with membranous nephropathy. Patients may often be asymptomatic, and venous thromboembolism is more common than arterial thrombosis. Infections are a very dreaded complications in these patients, and the risk is again more common in children and elderly. Patients who have frequent relapses or patients who are on long-term immunosuppression are obviously more vulnerable. Invasive bacterial infections like cellulitis, bacterial peritonitis, and sepsis are more common. And the infection is related to the degree of edema, because when there's subcutaneous fluid collection, it promotes bacterial colonization. There's loss of immunoglobulins and overall proteinuria. There's reduced complement in T cell function, and all this is further worsened by the use of immunosuppression. Acute kidney injury. So normally patients of nephrotic syndrome are supposed to have a normal renal function and normal serum creatinine, but acute kidney injury may develop, and those who are at highest risk are again elderly persons and children. Why it happens? Because patients have low serum albumin that promotes pre-renal AKI. Patients are hypotensive because of volume contracted state. For the swelling, they receive diuretics, which further worsens the volume contraction. Certain drugs used for the treatment can cause AKI. They are also vulnerable to sepsis, as we saw earlier, in renal vein thrombosis, which can cause or contribute to acute kidney injury as well. Why does dyslipidemia or hyperlipidemia occur in these patients? Because there's increased production of lipoprotein by the liver. The lipid catabolism is diminished. There's reduced plasma levels because of reduced plasma levels of lipoprotein lipase. There's increase in the total cholesterol, LDL, triglycerides, and lipoprotein A, and especially in adults, this becomes a risk factor for cardiovascular disease. Even in children, it has been shown that patients who have been nephrotic for a very long time with persistent proteinuria and high cholesterol levels, they have an increased risk of cardiovascular disease when they reach adulthood. And we should always remember that if the patient has persistent proteinuria, that actually promotes chronicity and progression to chronic kidney disease, and even can lead to end-stage kidney failure. So how do we approach a patient of adult nephrotic syndrome? So a patient will come to you with edema, as we saw. We need to confirm and quantify the amount of protein being excreted, which I will talk in detail later. We'll need to look for urine microscopy to see if there is any hematuria and active urinary sediment, which will give us some hint about additional hint about the disease. Like patients with IgA nephropathy may have hematuria. Patients with lupus may have hematuria. We need to do the kidney function test at baseline to look for acute kidney injury, serum protein and serum albumin, and of course the lipid profile. At the same time, while we are defining the nephrotic syndrome, we should also look for secondary causes. As I discussed earlier, underlying disease is important in adults, and that should be investigated for in detail. How do we look for urine protein? The easiest bedside test to do is a dipstick. So this is how a urine dipstick looks like, and as I told you earlier, this frothy urine. The dipstick is dipped in this, and after some time it is taken out. There's this color coding available, and if you look at it, the different color codes tell you how much protein the patient. So this is normal plus 1, 2, trace 1, 2, 3, and 4. And the color changes will be interpreted as a degree of proteinuria. So it's a semi-quantitative way of testing. Now a urine dipstick protein value of 3 or 4 plus semi-quantitatively means that there is a nephrotic range proteinuria, but it is not definitive. The best way to do is to measure the protein level in a 24-hour urine protein collection, but then this has issues because the patient, it's cumbersome for the patient to collect 24 hours and then bring it for testing. Also, because of daily activities, the patient may not be collecting the entire 24-hour urine sample, which may lead to errors in the quantification. So to assure that a 24-hour urine protein collection is adequate, it is not like the patient has collected only part of the sample, we should always ask for a urine creatinine as well. So the urine creatinine value will give us whether the patient has adequate collection of urine sample. To bypass this cumbersome nature of 24-hour urine protein collection, the other way to do it is do a urine protein creatinine ratio in a spot single morning voided sample, and it has shown to accurately estimate the 24-hour protein excretion per day. So if a ratio of urine protein creatinine is 3 mg per milligram, it means that the patient is passing 3 grams per day of urine. So many centers would just do a urine PCR or a urine protein creatinine ratio to monitor these patients rather than do a 24-hour urine sampling. Systemic investigations always in adults look at the diabetes status, look at viral infections, which are common causes of glomerular diseases leading to nephrotic syndrome, especially HIV, hepatitis B and C. Look for other autoimmune diseases like lupus, do the serum complement levels, the autoimmune serology. Look for paraproteinemias like myeloma, especially in elderly patients by doing a serum or urine protein electrophoresis. And then finally comes renal biopsy. Renal biopsy is in a patient with nephrotic syndrome. In adult, it is always recommended. That is how it differs from children. And it is needed to confirm the diagnosis because, as I said earlier, there is no predominance of any particular disease type causing nephrotic syndrome in adults, unlike children. So you cannot really say based on the clinical presentation, unless there is any underlying systemic disease present, that what is the histopathology. So it confirms the diagnosis, it gives us the pathological subtype of the disease, like in lupus it tells us whether it's lupus class 4 or class 5, and also gives us the disease activity and chronicity. Diabetes is the only exception, where every patient of nephrotic range proteinuria or nephrotic syndrome does not undergo a biopsy unless there are some specific indications, which I'm sure will be discussed when your seminar on diabetic kidney disease is done. Now we have got a diagnosis of nephrotic syndrome. What is the goal of therapy? First, the patient doesn't know, for him the biggest concern is his edema or swelling. So we need to reduce the edema for symptomatic relief. We need to prevent and manage complications, and we need to give definitive therapy to reduce the proteinuria to a lowest possible level, which is called induction of remission of proteinuria, and then maintain the remission and prevent further relapse or return of proteinuria. So treatment of nephrotic syndrome is classified as supportive management, as well as specific treatment. The specific treatment would be for systemic diseases and secondary glomerular diseases, or immunosuppression, which is required for primary glomerular diseases and certain systemic diseases like autoimmune disease, like lupus. So supportive therapy starts with dietary restriction. Since these patients have edema and they have renal sodium retention, salt restriction is important. Fluid restriction is important to promote a negative fluid balance, but protein restriction, though these patients are losing protein in urine, but excessive protein should not be given. At the same time, we should be careful of the protein restriction because it can lead to malnutrition. So isocaloric protein restriction to around 0.8 to 1 gram per kg per day is recommended in adults. Diuretics, again to reduce the swelling or the edema. It should be judicious because it can precipitate an acute kidney injury. So a targeted weight loss of around half a kilo to 1 kilo per day is recommended, so it should be closely monitored. Loop diuretics like furosemide or torsemide are generally used. These patients are often diuretic resistant, so higher doses may be required, and sometimes we may need to combine with distal diuretics, that is diuretics targeting the distal tubules like metalazone or potassium sparing diuretics to improve their efficacy. Hypertension is an important problem. It's common in nephrotic syndrome in adults, and adequate blood pressure control is important because it not only prevents progression of the kidney disease and loss of renal function, but also protects against cardiovascular disease. The target of blood pressure should be less than 130/80. Some would say for nephrotic proteinuria even less than 125/75 may be targeted. Lifestyle modifications are important. If antihypertensives are required, AC inhibitors and ARBs are first line of therapy. So AC inhibitors and ARBs are recommended to block the renin-angiotensin system in nephrotic syndrome patients even if they do not have hypertension. That is because in this case they are being used to reduce proteinuria. They cause preferential vasodilatation of glomerular efferent arterioles, which decreases the glomerular capillary pressure, which reduces the proteinuria. It also has a direct protective effect on the glomerular filtration barrier, which leads to reduction in proteinuria. So when we are seeing an acute patient presenting acutely with nephrotic syndrome, very low serum albumins, patient is hypotensive, at that time we should avoid ACE inhibitor initiation. We should wait for the patient to stabilize, blood pressures to stabilize before we start these drugs, and we should understand that the antihypertensive effect of ACE inhibitors and ARBs occurs within hours, but the reduction in proteinuria takes time. The maximal benefit in reducing proteinuria is seen in 4 to 12 weeks. Dose should be titrated with close monitoring. Some rise in serum creatinine is expected, but beyond that, if there is more than 30% rise or if there is hyperkalemia, it may require drug discontinuation. Dyslipidemia should be treated according to the guidelines. Usually a statin is used and it is well tolerated. Prevention of thromboembolism is important, especially in elderly patients or patients who have very low serum albumin levels, very obese, bedridden patients, or who have very heavy proteinuria. Usually subcut heparin or warfarin is used. Next comes treating the underlying disease. So obviously if we have found a malignancy presenting with a membranous nephropathy, then we treat the malignancy. We do not give specific treatment for membranous nephropathy, and most of the cases treating the malignancy will lead to reduction in proteinuria and resolution of the disease. Same thing for infections, viral infections and paraproteinemias. Of course, in autoimmune diseases like lupus, the treatment itself is immunosuppression. So comes immunosuppression, which is the mainstay of treatment of nephrotic syndromes, used in both primary and secondary glomerular diseases. The goal is to reduce proteinuria and maintain stable kidney function, but the treatment, our target should be to minimize the exposure to immunosuppression, to prevent complications, but at the same time maintain remission without relapses. How do we assess the response to immunosuppression? How do we assess the response in nephrotic syndrome patients as such? It's induction of remission. Remission is defined as complete and partial remission. Complete remission is reduction of proteinuria to less than 0.3 grams per day, or a urine protein creatinine ratio less than 0.3 or 300 milligrams per day, with a normal serum creatinine and a serum albumin of more than 3.5 gram per deciliter. Partial remission is defined as reduction of proteinuria to less than 3.5 gram day, with at least a 50% reduction from a baseline, but more than 0.3 gram per day with a stable serum creatinine. So coming to some common primary glomerular diseases, glomerular diseases which are seen in adults. Minimal change disease. So I'm going to talk about minimal change disease, FSGS, and membranous nephropathy chiefly. Minimal change disease is a prototypical manifestation of both minimal change disease and FSGS are manifestations of the podocyte injury. So initially they were discussed as different entities, but now it's recognized they are basically different manifestations of the same underlying disease process. Because of some reason the podocytes are damaged, their food processes are effaced, and because of that the filtration barrier is compromised. The early stage of the disease patients do not show any abnormality in the kidney biopsy, though they are losing protein in urine, so that's minimal change disease. While as it progresses, histological changes develop and patient develops an FSGS. So this podocyte injury may be because of multiple causes, which leads to the food process effacement, like it could be idiopathic or immunological, it could be genetic, it could be virus infections, drugs, malignancies, or it could be an adaptive, especially in adults. And if there is no change in the number, it's minimal change disease. If podocytes are being lost, it leads to secondary glomerular sclerosis, and if there's podocyte proliferation, there's collapsing glomerular nephropathy, which is a more aggressive disease. So idiopathic, when we are talking of nephrotic syndrome with minimal changes in FSGS, we are talking of idiopathic, which is the predominant cause in 80 to 90% cases. Now when we are talking of FSGS, as I said, adaptive damage changes can also lead to podocyte damage, and that causes secondary FSGS. So we should differentiate primary versus secondary FSGS before starting treatment. Secondary causes may not always be detected as such, it may not be evident, but it can be caused by hypertension. Common causes are hypertension, reduced renal mass like nephrectomy or a solitary kidney, or reflux nephropathy. We should remember that secondary causes are more common in adults compared to children. How can they be differentiated? Histologically, electron microscopy. Patients with primary idiopathic FSGS will have diffuse podocytopathic changes. on electron microscopy, while secondary causes will have segmental changes. The clinical presentation also differs. Patients with primary FSGS will have nephrotic syndrome, the full constellation of symptoms, while patients with secondary FSGS will have nephrotic range proteinuria, which so patients will have proteinuria, but there may or may not be edema. Serum albumin is usually normal, and lipid abnormalities may not be present. This differentiation is crucial in adults because patients with secondary FSGS should not be treated with immunosuppression. They should get supportive treatment only, or if there's an underlying cause like a viral infection, should be treated, but immunosuppression should not be given to these patients. So let's look at a clinical situation. We have a young male with edema, proteinuria, low serum albumin. Kidney biopsy has an FSGS, started with supportive therapy and given immunosuppression. We should remember these patients do not respond to just supportive therapy. Less than 5% chances of spontaneous remission is there. So they're usually treated with steroids. They have broad spectrum anti-inflammatory effects. Adults are usually treated with 1 milligram per kg per day with a maximum dose of 80 milligrams or an alternate daily dose of 2 milligram per kg. Minimum duration of therapy is 4 weeks and a maximum duration of therapy is 16 weeks. Extending treatment beyond 16 weeks if patient is not responding is unlikely to benefit, and these patients should be labeled steroid resistant. Once patient achieves remission, the treatment should be tapered slowly over a period of up to 6 months of total duration of steroid therapy in adults, and earlier rapid tapering is believed to trigger disease relapse in these patients. So as I said earlier, you have to give steroids for minimum 4 weeks, maximum period of 6 weeks, and a slow tapers for a total duration of 6 months. Though the response rate is good, about 70% in a minimal change disease and around 60% in FSGS, these patients do tend to relapse. Relapses are more common in minimal change disease compared to FSGS. Now, a patient had 2 relapses while tapering steroids, and he was started on oral cyclophosphamide. So when we are talking of second line of immunosuppression, when are they given? They are given in patients who have frequent relapses, which is defined in adults as 2 relapses in 6 months or 4 relapses in 12 months. Steroid dependent patients who have 2 relapses during or within 2 weeks of completing the steroid therapy, and in steroid resistant patients who have not responded despite 16 weeks of full steroid treatment. It also may be given in patients who are steroid intolerant or where steroid therapy is contraindicated. What are the therapies given? Cyclophosphamide, which is an alkylating agent, and it is usually used in steroid dependent or frequent relapsing patients. They may be given orally or as a daily dose, or IV pulse therapy, which some studies have suggested has associated with reduced adverse effects. Should not be given for more than 8 to 12 weeks because there's a risk of serious adverse effect, long-term adverse effects, and should not be repeated more than once. It causes bone marrow suppression leading to leukopenia and thrombocytopenia. It can cause serious infections, hemorrhagic cystitis, and long-term can cause gonadal toxicity and has an increased carcinogenic effect. Calcineurin inhibitors are an immunosuppression which are commonly used in renal transplantation. They inhibit T cell activity predominantly, and they're used mainly in steroid resistant nephrotic syndrome patients and as an alternate in frequent relapsing or dependent patients. The 2 drugs available are cyclosporin and tacrolimus. They have a narrow therapeutic index, so drug level monitoring to adjust doses is crucial, and they have multiple adverse effects including nephrotoxicity. They are expensive. A longer duration of treatment is required, up to 1 to 2 years in adults, and the biggest problem is that they're associated with high relapse rates on withdrawal of the drug. The other alternative drugs which have been studied include mycophenolate mofetil, which is an anti-metabolite drug, so it inhibits both T and B cell proliferation, and rituximab, which is an anti-CD20 antibody that depletes B cells. Rituximab has mainly been studied in steroid-dependent nephrotic syndrome or patients with frequent relapses. They have a relatively poorer response in steroid-resistant patients. If you look at the long-term outcome in FSGS, patients do progress to end-stage kidney failure, especially if they are steroid resistant and do not have persistent proteinuria. Even in patients who achieve remission, those who have partial remission are at a higher risk of developing or progressing to end-stage kidney failure compared to those who have complete remission. So achieving remission is essential to prevent progression to CKD and end-stage kidney disease in these patients. Lastly, coming to membranous nephropathy, which is one of the 3 most common causes of nephrotic syndrome in adults. It is more common in the elderly. Secondary causes are relatively more common in this disorder, and it's maybe seen in up to 30% cases. So any patient who presents with a membranous nephropathy on kidney biopsy should always be investigated in detail for common secondary causes. Primary membranous nephropathy is an immune-mediated disease, and now there is an antibody which has a couple of antibodies which have been identified, there's a causal relation with the disease. Anti-phospholipase A2 receptor antibody is the main antibody. It is seen in up to 70% patients of membranous nephropathy. It's an antibody directed against phospholipase A2 receptor, which is present on the podocytes. If you see here, there is immunological activity starts first and the clinical disease follows later. So when you treat, the antibody level actually comes down before the clinical disease goes into remission. The antibody can be assessed quantitatively using an ELISA assay. Now, how does membranous nephropathy behave? 1/3 of these patients will go into spontaneous remission just with supportive therapy and will not require further immunosuppression, while the remaining patients will need specific treatment. 1/3 of the patients progress to end-stage kidney disease, so the risk of ESRD is there. So looking at a patient who presents with membranous nephropathy, as I said earlier, secondary causes should be always ruled out. The common investigations done to rule out secondary causes, we should look for autoimmune diseases, especially lupus, infections, hepatitis B, C and HIV, mainly hepatitis B. Some drugs have been commonly reported to cause membranous nephropathy, and most common thorough malignancy screen, age-specific malignancy screens should be done in these patients because underlying malignancies are common. When you give supportive therapy, when and how long, it should be given for at least 3 to 6 months before progressing to immunosuppression. It comprises of salt restriction, diuretics, protein restriction and ACE inhibitor therapy in the maximum tolerated dose. Unfortunately, our patient did not respond to supportive therapy. His proteinuria increased to 8 grams per day with an albumin less than 3 grams, as you see here, and his edema persisted. So he was counseled for starting immunosuppression. So when we start immunosuppression, while starting immunosuppression, we need to assess the severity of the membranous nephropathy. Patients are usually classified as low risk, medium risk and high risk. Low risk patients, if the proteinuria is less than 4 grams per day for 6 months with supportive therapy. Medium risk if there is proteinuria 4 to 8 grams per day, and high risk where the patient has a proteinuria more than 8 grams or a rising serum creatinine 2 to 3 months after starting supportive therapy. For medium and high risk patients, immunosuppression should be started. For low risk patients, we should keep on monitoring every 3 months, and if at any stage there is an increase in proteinuria, we should start immunosuppression. Immunosuppression should be contraindicated if the patient's creatinine is high, more than 3 milligrams per deciliter, or the eGFR is less than 30, or the significant chronicity on kidney biopsy. Cyclophosphamide was the mainstay of treatment for membranous nephropathy till a few years back. It was used in combination with steroids, what is called the modified Ponticelli regimen. It consists of 6 monthly cycles alternating steroids and oral cyclophosphamide. 70 to 80% patients would achieve remission, 20 to 30% would relapse subsequently. After completing the Ponticelli regimen, one should wait for at least 6 months before considering treatment failure, unless the kidney function is deteriorating or there is worsening proteinuria or edema, because sometimes even after finishing therapy it takes 2 to 3 months for the response to manifest. The alternate drug is calcineurin inhibitors, cyclosporin and tacrolimus. They can be given on their own, while some centers would combine it with low-dose steroids. A trial of 6 months should be given before presuming that the patient is resistant to therapy. Again, a response takes time. Once remission is induced, the treatment should be continued for at least 12 to 18 months before reducing the dose gradually, because otherwise there's a high risk of relapse. It's an expensive drug, and longer duration of therapy leads to non-compliance, and there are high relapse rates on withdrawal. So it's not ideal, but considering the lower incidence of adverse effects compared to Ponticelli, and it can be used as an alternative, especially in young patients. The third drug, which now has almost become a mainstay of treatment for membranous nephropathy, is rituximab. 50 to 60% patients would respond, and both for first-line treatment and in immunosuppression-resistant disease. Again, response takes time, up to 6 to 9 months, and relapse rates are similar to calcineurin inhibitors. Biggest advantage is that compliance is ensured, since it's given as a single-time therapy with 1.5 to 2 grams infusion. Anti-PLAR antibody can be used to monitor response to immunosuppression therapy in membranous nephropathy now that it is commercially available. If you look at alternate immunosuppression, we should remember that this is one type of nephrotic syndrome where steroid monotherapy should not be used, unlike minimal change disease in FSGS, because it has shown poor response, and even in patients who do respond, the relapse rates are very high. Mycophenolate mofetil is not routinely used because it has again shown a very inconsistent response and high relapse rate, but may be tried in resistant disease. So to summarize, nephrotic syndrome is common in renal clinics in adult patients. All adult patients with nephrotic syndrome need a kidney biopsy because there is no disease which is predominant. Minimal change disease, FSGS, and membranous nephropathy are the common patterns seen on kidney biopsy. Immunosuppression is a mainstay of treatment, but it should be optimized to achieve and maintain sustained remission, at the same time minimizing the adverse effects. And we should remember that persistent proteinuria can lead to progression to end-stage kidney disease.
Hi, good afternoon. I hope you would have access to the lecture on Saral. I'm just trying to log in there and see if I can get it down from there. You've had a introduction into nephrotic syndrome by Dr. Shaumita just now, and I'm sure you now understand what the causes of adult nephrotic syndrome are. I should take you through pediatric nephrotic syndrome. I'm just waiting for my slides to load up here. Just give me a minute. So how do they see my slides? Like, how does it go onto the display mode? I mean, this is live streaming what? Our face, the slides, what is it? The screen? How do you know? How do you know? That chap has to be there. Yes, but the slides, I hope it's showing up the slides. Now they can see the slides, yeah. Okay. What do we do? I don't think there are any. Do you have any questions for Dr. Shomita? Are any of you live at all? Okay. I think we just go on. Yeah. Okay. So the management of nephrotic syndrome in children is a bit different than in adults. And in adult patients compared to in children, you have a different set of histologies and a different plan of management. But overall, the idea is that both adult and pediatric nephrotic syndrome has an immune basis, and that's why immunosuppression forms the cornerstone of management of nephrotic syndrome in both children and in adults. Now, nephrotic syndrome, the definition of nephrotic syndrome has already been clarified to you by Dr. Shomita, and she told you that how it is characterized by edema along with nephrotic range proteinuria and low serum albumin. So the albumin threshold that we used to use was 2.5 grams per deciliter, but even at a serum albumin level of below 3 grams per deciliter, one would consider a diagnosis of nephrotic syndrome provided there is edema and proteinuria of nephrotic range. Now in children, quantifying this kind of proteinuria based on a 24-hour urine is not always feasible, nor is it practical to collect all the urine because all children are not toilet trained. So we often use spot urine samples, and in spot urine samples, if you were to demonstrate that the protein excretion is such that the ratio of protein to creatinine exceeds 2 milligram per milligram, then it is nephrotic range proteinuria. The other way to look at proteinuria in urine spot samples is by a semi-quantitative estimation using a dipstick. So, a urine protein dipstick semi-quantifies the proteinuria, and it is graded from nil protein to trace, 1 plus, 2 plus, 3 plus and 4 plus. Anything that is running 3 plus or 4 plus proteinuria corresponds to more than 1 gram per liter of protein in the urine, and that is considered nephrotic range. Anything more than 300 milligram per deciliter is considered nephrotic range. So, that is how you look at proteinuria in children. And majority of children would have what is known as steroid sensitive nephrotic syndrome. We broadly classify nephrotic syndrome in childhood as steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome. Overall, on its own, nephrotic syndrome is a very rare disorder. As you can make out from the slide here, its incidence and prevalence is a few children per 100,000 child population. So the prevalence is like less than 20 per 100,000 children, and incidence is obviously much lower per year. Majority of these children, about 85 to 90%, would have what is called a steroid sensitive nephrotic syndrome, and a small proportion, about 10 to 15%, would have steroid resistant nephrotic syndrome. Now, this resistance to corticosteroids is usually present at onset of the illness itself. That is called initial steroid resistance. However, sometimes it may happen that steroid sensitive nephrotic syndrome that goes into remission with steroids later, when it has relapsing course, sometime later following a disease relapse, you might have steroid resistance, in which case it is called late steroid resistant nephrotic syndrome. Overall, this pie diagram indicates how the course of steroid sensitive nephrotic syndrome might be. Now, these two pies depicts two pies that are drawn from a large study called the International Study of Kidney Diseases in Childhood in 1970s, and our own experience of patients followed from onset of disease. And you can make out that the majority of patients in the international study, about 44%, had just a single episode. About 22% had infrequent relapses, that is very few relapses per year, whereas 1/3 of patients had frequent relapses. In contrast, the children followed at our center seem to have less often a sustained remission, that is no relapses at all, or infrequent relapses, and almost half of them had either frequent relapses or steroid dependence. Now, overall, this is how complex and limited our understanding of the pathogenesis of nephrotic syndrome is. We believe that nephrotic syndrome is an immune mediated illness. However, we don't precisely know what causes nephrotic syndrome in children. What we do know is that both the onset of the illness and disease relapses are often triggered by some triggers to the immune system. Now, these triggers could be a minor viral infection, it could be an event such as a vaccination event, or even sometimes things like bee stings which cause, say, IgE responses to mount up or things like that. Those could cause nephrotic syndrome relapse to happen. Now, we don't know precisely what is that antigen, but maybe the naive immunity and also the T helper subsets, maybe of the Th2 kind or the Th17 kind, are upregulated, vis-a-vis the Th1 or Th regulatory subsets are downregulated, and the perturbation of this balance results in production of some kind of a cytokine. We still don't know what cytokine, that circulates in the blood and probably goes and acts on the glomerular podocytes to change their morphology and cause the food processes, that are interdegenerating food processes, to be effaced such that the podocytes can no more stop proteinuria from happening, that is, the filtration barrier's integrity is lost and proteinuria happens. Now, patients with steroid resistant nephrotic syndrome may or may not have a similar basis of disease. They may or may not have the same immune perturbations, or they may have more severe immune perturbations, or maybe their disease results from something else, some other kind of a circulating factor. This is not very clearly understood, and a variety of molecules have been proposed to be those circulating factors. We do think that in the majority of patients this is a circulating factor disease. There is a variety of experiments that have provided this evidence that there is something circulating in the plasma or blood of the nephrotic patients that goes and acts on the podocytes to cause changes in its architecture and its filtering abilities. Overall, you know from your pathology days, and Dr. Gitika is going to talk to you about it as well, that the majority of patients with especially steroid sensitive nephrotic syndrome would have nothing under the light microscope and nothing on immune fluorescence, and just food process effacement that would be visible on the electron microscopy. This is called as minimal change disease. A fraction of patients, and predominantly the patients who have steroid resistant nephrotic syndrome, would have the lesion known as focal segmental glomerular sclerosis on their biopsy. It is the patients with steroid resistant nephrotic syndrome that we chiefly tend to biopsy. A fraction of these patients with steroid resistant nephrotic syndrome do not have an immune mediated disease, and about 30% of these patients, and these would be patients who would have steroid resistance right from the beginning of their disease, that is at onset of their illness. They are perceived to have a disease which is mediated by some mutation in some gene which encodes for some key podocyte protein, such that the podocytes are not continuing to have an intact filtration barrier. And more than 90 genes are now described. In fact, almost every week or every 2 months you get a new gene discovery that is responsible for nephrotic syndrome. So we now have more than 90 genes that are described that can cause potentially steroid resistant nephrotic syndrome. Now, guidelines on management of childhood nephrotic syndrome are available for a variety of societies, and we shall go over just the Indian Society of Pediatric Nephrology guidelines, because these are what is most relevant, and these are just about to be revised this year. A draft has been prepared and is in circulation and should be published soon. Other guidelines from societies, international bodies, are the International Pediatric Nephrology Association and the Kidney Disease Improving Global Outcomes. So very broadly, what you need to remember is this, that patients who go into remission of proteinuria, who have nil or trace proteinuria, following treatment with prednisolone in adequate doses, within 6 weeks interval from start of therapy, are termed steroid sensitive nephrotic syndrome. Patients who do not enter remission, that is, they continue to have some proteinuria despite 6 weeks therapy with prednisone, are considered to have steroid resistant nephrotic syndrome. As already outlined to you, this resistance could be present at onset of disease when it's called initial resistance, or it could occur following some subsequent relapse when it's called late steroid resistance. What has changed recently is this duration. Previously we used to term it at 4 weeks, and now we have moved towards a more longer duration, that is 6 weeks, because we do know that between 4 and 6 weeks few more patients would enter remission on their own or with therapy with prednisolone. So we tend to wait a bit longer before labeling them as steroid resistant nephrotic syndrome. Now, disease relapse is once you have had remission of proteinuria, afterwards if you have recurrence of nephrotic range proteinuria with or without edema, that is termed as a disease relapse. For management reasons and to look out for steroid toxicity, we tend to define a subgroup of steroid sensitive nephrotic syndrome as having frequently relapsing disease. We need to define that because these patients would then be at risk of significant corticosteroid toxicity, and we need to change their approach to management. So, any patient who has 2 or more relapses in the first 6 months after stopping the initial therapy would be termed as having frequent relapses. Also, anybody who has 4 relapses in any year or more would also be termed as having frequent relapses. Patients with frequent relapses may sometimes have such frequent relapses that they cannot manage to be off corticosteroids. That is, the moment you stop steroids or within 2 weeks of stopping steroids, or even when you step down to alternate day steroids, they might tend to relapse. Such patients are an even more difficult group of patients. So those are called as steroid dependent nephrotic syndrome. So overall, steroid sensitive nephrotic syndrome is considered to be a disease with a favorable outcome. Most patients on the long term would enter long term remission. By the time they are adolescents or they enter puberty, they are usually outgrowing their disease and the disease goes away entirely. Most of the patients, once they have steroid sensitive nephrotic syndrome, they would enter remission, then they would have relapses at a certain frequency. The frequency of relapses usually gets lower and lower as the child gets older, and then the disease goes away around puberty. But it's not always a very innocuous disease. The disease relapses, if they are left untreated for a long time, they can have several complications. So they can be hypovolemia, because there is incipient hypovolemia in the blood, serum albumin being low, oncotic pressure being low. There is actually hypovolemia even when there is severe edema that is present. So these patients would require admission. Patients with severe edema would require admission since the diuretics are unable to manage the edema on the outpatient basis. Or there could be severe infections such as peritonitis, cellulitis. These are infections with gram-positive organisms, immunity against which is lost during disease relapses when antibodies and complement factors are lost in the urine. There is also a tendency to have thrombosis in severe relapses because the hematocrit rises, because the oncotic pressure of the blood being low, everything there is low blood volume overall, and there is loss of anticoagulant factors, which leads to a tendency to have thrombosis. Then again, because each time you have to hike up steroids, there's risk of significant steroid toxicity. So we have listed here some steroid side effects that many of these patients might develop. Then there could be patients who keep on having frequent relapses despite trying one drug or another, and these are really difficult to treat. So overall, what you need to remember is how you evaluate and diagnose nephrotic syndrome. So essentially, the diagnosis of nephrotic syndrome is a clinical diagnosis based on the presence of edema in a setting of hypoalbuminemia and nephrotic range proteinuria. You also need to ascertain that the renal function is otherwise normal. Usually the blood urea and creatinine levels would be all right. There should be nothing much else going on in the urine, that is, there will be no red cells or WBCs really in the urine. The urine sediment would otherwise be bland. We look at serum levels of albumin. We also expect cholesterol to be elevated. The liver synthesizes a lot more lipid because it's trying to synthesize more albumin, and in the process hyperlipidemia happens. Since we are going to treat these patients with corticosteroids, and in our country the prevalence of tuberculosis is rather high, so we also do a tuberculin test at onset of nephrotic syndrome to try to ascertain whether these patients are at risk of developing tuberculosis or not, and take action based on that. Additional evaluation that patients might require at onset or relapse are listed here. So you can imagine that most of these tests are not required. They are required only in specific settings. So if you have, for example, a tuberculin test that is positive, then you would want to understand whether the child already has tuberculosis or not, and therefore you would perform a chest radiography. Or if there is history of contact, only then you would perform that, otherwise you wouldn't. Or else a child has come in with tachypnea or a setting of pneumonia, then you would perform it. Kidney ultrasound is essentially not required in a typical nephrotic syndrome, but if you are planning a biopsy for some reason, then you would want to perform it, or if you are suspecting a complication, then you would perform it. Blood levels of electrolytes and urea creatinine, it's a good idea to look at if you have a child who is very, very edematous or has signs of hypovolemia, etc. Certain tests that are listed at the bottom of this page, such as complement levels, ANA levels, these are not necessary in most children with nephrotic syndrome. Sometimes you might have an older child in which you are confused whether this child has post-streptococcal glomerulonephritis, or what is now known as infection-related glomerulonephritis, presenting with a picture of hematuria, oliguria, puffiness. Therein you would want to do these tests to understand whether this is typical nephrotic syndrome or it is glomerulonephritis. So most patients with nephrotic syndrome presenting in childhood would not require a kidney biopsy. This is contrary to what is advised for adult nephrotic syndrome. Patients with nephrotic syndrome usually do not undergo a biopsy if they are children. This is only in a setting of steroid resistance, or if you have atypical features in which you are not sure whether the diagnosis is indeed minimal change disease, would you require a kidney biopsy. And in the majority of patients, if you were to biopsy these children, the diagnosis would be minimal change, except in a setting of steroid resistance where FSGS, that is focal segmental glomerulosclerosis, would be a usual diagnosis in almost half the patients. As the child gets older, histologies that are more prevalent in adult patients begin to become more prevalent. So in older children, you also see entities such as membranous nephropathy, IgA nephropathy, and membranoproliferative glomerulonephritis. Dr. Gitika shall be talking to you more about some of these histologies. Indications for kidney biopsy in childhood nephrotic syndrome are therefore very limited. One important indication that I already told you is corticosteroid resistance, whether it's initial or late corticosteroid resistance. Then there are certain atypical features at onset which make you suspect a presence of a glomerulonephritis, such as gross hematuria or persistent microscopic hematuria, a low C3 level, systemic features such as fever, rash, arthralgia, which indicate entities such as systemic lupus erythematosus or other entities. Any child who has sustained hypertension, therein also you worry about a glomerulonephritis. We also tend to perform kidney biopsy in the context of therapy with calcineurin inhibitors. Dr. Shomita has already told you about calcineurin inhibitors being the front line of therapy of steroid-resistant nephrotic syndrome, and these therapies are associated with chronic and acute nephrotoxicity, and if you are going to use them for a long period of time, you would want to do a kidney biopsy because they can cause interstitial fibrosis, which will not be picked up on blood tests and would require a biopsy to pick these findings up. So initial prednisolone therapy for childhood nephrotic syndrome is much shorter than an adult type of nephrotic syndrome. This graph at the bottom, at the top of the page shows to you how children enter remission faster, and you can make out that most children are in remission by 4 weeks. A very small proportion would enter remission further on, while in adult nephrotic syndrome it takes much longer. So the original regimen proposed by studies in the 1970s suggested that daily therapy for 4 weeks and 3 times a week therapy for 4 weeks would be adequate, and more or less that has stood the test of time. There have been studies in between that have suggested that very long therapies might be much better, but what does better mean? You would want a therapy that ensures that the child stays in remission for a good interval of time, but also that the disease, if it comes back, when it relapses, it does not relapse frequently. So overall, what we now understand is that daily therapy for 6 weeks and alternate day therapy for 6 weeks, or even 4 weeks and 4 weeks, is fairly adequate. So the Indian Society of Nephrotic Syndrome advocates using 2 mg per kilogram or 60 mg per meter square daily for 6 weeks, followed by 1.5 mg per kg on alternate days for 6 weeks. Even 4 and 4 weeks would be sufficient, but this is what the guideline has been and we'll stay by it, 6 weeks and 6 weeks. What about disease relapses? Therapy of disease relapses is given in the same dose daily, but the duration is much shorter. We only give therapy for as long as it takes for protein to become nil or trace. So when the protein is consistently nil or trace for 3 to 5 days, we switch therapy to alternate days and give it for another 4 weeks. Now this is very empirical and does not have any real evidence from studies, but now studies are being conducted on trying to understand whether the dose or the duration of the therapy can be curtailed further. So far we don't have enough evidence, so we stay by this at the moment. So we are trying to understand this better. What about frequently relapsing patients? So in a nutshell, this is what our kind of management algorithm is. So what happens is that if a child were to show frequent disease relapses and each time you were to go back and treat them with high dose corticosteroids, if you have say 4 relapses in a year, so you would receive 4 courses of almost 50 mg per kilogram steroids in a year, and that kind of cumulative corticosteroid toxicity builds up and causes lots of side effects, We don't want that to happen. So once you pick up that a child is having frequent relapses, you don't give these short courses of high dose steroids. You modify the treatment in a way such that you, following relapse treatment, you taper and cut down steroids and come down to a small dose, say maybe at about 0.5 milligram per kilogram on alternate days, and carry on giving that dose for 6 to 12 months. It is also shown that since infections trigger a lot of relapses, when we make that dose daily during infections, that helps. Studies have shown that making the same dose daily while you are on alternate day helps prevent a relapse. So the first strategy in managing patients' frequent relapses has traditionally been giving prednisolone on alternate days at a low dose of about 0.5 milligram per kilogram alternate day. Patients who continue to show frequent relapses on this strategy, those patients you kind of worry about. So you worry about what drug they need to be given. You try further another immunosuppressive strategy which can cut down the frequency of relapses. So among these, two agents are considered relatively milder, levamisole and mycophenolate mofetil, and equivalent in efficacy. So we try these first. Why we try these milder agents first is because they are also safer for the child. Their adverse effect profile is not that profound. You don't have too many toxicities associated with them. They do require monitoring with complete blood counts and other tests, but overall they are good agents and they allow many children to go off steroids completely. On the other hand, if someone has a very bad tendency to relapse, has severe relapses requiring admission, has a lot of steroid toxicity and you want to get them off steroids entirely, you try something stronger than that. You can try them having failed these other agents, or you can try them directly if they are behaving like very severe steroid dependent right from the onset. And MMF, when given in high doses, or oral cyclophosphamide, a course of oral cyclophosphamide, are considered good therapy to try out for this. Patients who fail these agents, you would try CNIs, that is calcineurin inhibitors like cyclosporin or tacrolimus, and failing these, you would try agents such as rituximab, which has recently shown promise in curtailing steroid-dependent nephrotic syndrome relapses to a significant way. So these therapies such as calcineurin inhibitors and rituximab come much later in disease course or in disease severity. The first line agents that we try out are long-term alternative steroids, followed by levamisole or mycophenolate mofetil and or oral cyclophosphamide. So all of these therapies, we've listed here what doses we would use and for how long we would use them and what adverse effects we would want you to monitor them for. So these are standard immunosuppressive agents in your pharmacology textbooks as well as other textbooks, and you can make out that all of these are associated with certain toxicities that you need to watch out for on the long term. Each disease relapse carries the risk of certain complications, and I mentioned this to you before, that patients with nephrotic syndrome relapses or even at onset are at risk of complications such as anasarca and hypovolemia, and these are some signs that you must watch out for. So a child with edema and nephrotic syndrome might have edema, that is apparent fluid overload, but he might actually be clinically hypovolemic. This is because the Starling forces determine what stays in the blood compartment. So if the oncotic pressure is really low, the actual plasma volume might be very low. So these patients would have ischemia to various organs and tissues, and that would manifest as abdominal pain because of mesenteric ischemia, drowsiness because of cerebral ischemia. The extremities will be cold, they might be pallor, prolonged refill time, tachycardia and low blood pressure indicate a child who is severely hypovolemic. Then there could be certain biochemical indices which are more subtle. So you would have a tendency towards oliguria, you would have a tendency towards preserving sodium by the body. This all happens in the setting of, and then also an elevated hematocrit. So whenever you are managing a child with a bad relapse or onset of nephrotic syndrome, you always assess for hypovolemia first, because while edema you would want to manage with diuretics, you do want to be sure that you're not going to cause the child further injury by giving diuretics. We do know that diuretics are going to draw out blood further, volume further from the blood compartment. You don't want to push someone into hypovolemia. So first you assess for hypovolemia. If hypovolemia is present, in fact volume takes precedence and you manage hypovolemia first, regardless of the edema, using fluids and IV hydration and IV albumin. On the other hand, someone who doesn't have hypovolemia, you can go on and try diuretics in those patients. So most patients with nephrotic syndrome, if they come to clinical attention in time, they would not require any management for their edema. If you start steroids, they'll enter into remission and just minor salt restriction is sufficient. On the other hand, someone who has a lot of edema, therein you'd require salt restriction, you'd require diuretics, and various diuretics can be used. You try out furosemide because it's a good loop diuretic, it causes good diuresis, but other diuretics such as thiazides might need to be added on. Patients who don't do well on oral therapy might require IV therapy, and finally giving IV albumin along with IV furosemide is always a good idea in patients who are refractory to these measures. When we are using these agents, we have to be careful about side effects of diuretics such as hypokalemia. So using a potassium sparing diuretic such as spironolactone becomes useful for these patients. Okay. Another important complication of nephrotic syndrome is the occurrence of severe bacterial infections. Now, when we have proteinuria happening in nephrotic syndrome, there are losses of various complement proteins, there are losses of antibodies against encapsulated organisms, and therefore patients with nephrotic syndrome tend to be susceptible to certain infections by Strep pneumoniae, Staph aureus and other organisms. So, because of the edema, which is a good ground for bacteria to proliferate, there can be infections. So, in the ascites, there can be spontaneous bacterial peritonitis. In the skin, where there is edema, there could be cellulitis. In the chest, if the lungs are wet, there could be pneumonia. Patients would therefore, if they are left untreated, they could get sepsis. A viral infection that can be severe in these patients is varicella. So, basically this slide outlines the principles of diagnosis and management of these patients. Many of these complications would require admission to the hospital. An important consideration therefore is how to prevent these infections, and therefore immunization becomes a very important aspect. So, patients who are on immunosuppression are definitely not candidates for live vaccines, and this slide just kind of gives you a picture that we are worried when using live vaccines in patients who are on steroids. So, someone who is receiving high dose steroids, you cannot give live vaccines. When can you give? How can you give? This is what is outlined over here, just a snapshot. Even for household contacts and immunocompetent siblings, you would need to worry about use of live vaccines. What about vaccines that seem to be necessary in these patients? This slide kind of summarizes that advice, that you would want to give certain additional vaccines, particularly the pneumococcal vaccine, the varicella vaccine, annual influenza vaccine, and vaccinate them against hepatitis B, because in the future there might be some people who would go on to have advanced kidney disease. So, all in all, steroid sensitive nephrotic syndrome, this is how you would manage. I would just give a very brief overview of how to manage steroid resistant nephrotic syndrome, which constitutes just about 10 to 15% of all nephrotic syndrome in childhood. So, any child who does not enter into remission despite 6 weeks daily steroid therapy is considered to be steroid resistant. This could be at onset, that is initial resistance, or delayed, that is late resistance. In adults, the definition, as you've heard from Shomita, is very different. These patients you must evaluate very carefully. All these children must undergo a kidney biopsy. You must do a baseline estimation of proteinuria and estimated GFR on these children. You also do certain other tests because you're going to go on to use more immunosuppressive agents. We would biopsy almost all these children except children who are really young, in which we prefer to do genetic studies and biopsy is not required. Why genetic studies? We know that a proportion of these patients, particularly the initial steroid resistant ones, might be because of mutations in genes encoding key podocyte proteins. Now, the likelihood of having a genetic disease is the highest in the youngest age group. So, patients who present in the first 3 months of life with nephrotic syndrome are called congenital nephrotic syndrome. Therein, a genetic cause is found in as high as 80% of cases. On the other hand, someone who presents through 3 to 12 months of infancy, they tend to have an inherited cause in about 60% of cases. As you get older, the likelihood of having a genetic cause gets to be lower and lower. Overall, more than 90 genes are described and form the basis of disease in about 30% of cases. Patients, if we were to try immunosuppression on these patients, they would not respond to immunosuppression. So, we tend to reserve genetics for infants with nephrotic syndrome of steroid resistant kind and patients who have not responded to the first line therapy for steroid resistant nephrotic syndrome. Any patient who has a family history, who has progressed to chronic kidney disease, or who has syndromic features, they are also candidates for genetic studies. Overall, the other non-genetic patients would tend to respond to immunosuppression in about 70 to 80% cases. So the front line of therapy for patients with steroid-resistant nephrotic syndrome is calcineurin inhibitors, similar to that in adults. So 50 to 70% of these patients would enter complete or partial remission, usually within 3 months of time. Therapy with calcineurin inhibitors needs to be given on the long term for about 2 to 3 years, because if you were to stop short and stop early, you would tend to have disease relapses, and then again you would be in trouble again. So at least a year or 2 years you would continue therapy. Usually we give it 2 to 3 years, and then we contemplate whether we can take off the calcineurin inhibitors, or we need to switch to another agent, or we do another biopsy and check whether there is no toxicity of calcineurin inhibitors, and then we can carry on. What about patients who do not respond to calcineurin inhibitors? Therein you must do genetic studies, as we've discussed already, because these might be patients who have a genetic basis of the disease. If you don't have a genetic basis of disease, beyond that you can try some empirical therapies, but there's not enough evidence to recommend any one line of therapy. Some patients may respond to therapies such as rituximab or addition of mycophenolate mofetil. There are other agents that have been tried, various monoclonal molecules have been tried, but none of these have shown enough promise in controlling the disease. So other things that you must do, one important part of management of steroid-resistant nephrotic syndrome is the use of ACE inhibition or ARBs in all patients, because by their non-immune action of antiproteinuric action is very, very important in curtailing proteinuria. We also have to pay attention to various aspects of supportive care similar to steroid-sensitive nephrotic syndrome. These patients might be at risk of thrombosis because of loss of anticoagulant proteins. You have to worry about dyslipidemia in these patients. There are various other aspects which, for lack of time, we would not dwell upon. But suffice to say, this is how you would manage these patients with steroid-resistant nephrotic syndrome. You start with calcineurin inhibitors, add on ACE inhibitors, do good supportive care, assess response. If patients respond, you carry on calcineurin inhibitors and taper steroids, monitor them on the long term. If they relapse, hike up the steroids. If they continue to show a relapsing illness, you cannot take off CNI, you can think about switching therapy to another agent. For patients who don't respond to this therapy or already have a monogenic basis, only good supportive care is all you can provide for them, and they are at high risk of kidney failure. So that I'll end here, and I'll invite Dr. Geetika for her discussion on pathology.
We just talk into this, right?
Yeah, okay. There's nothing else. Can you just log? Carry on, carry on.
So you had yours on
Yeah.
So, okay. Bye. Yeah. Okay, so we just get into the pathology. Just give me a minute. Okay, so before we get into the pathology, we're just going to talk a little bit about the structure and function of the glomerular filter. Because we're discussing nephrotic syndrome, we understand that there is heavy protein loss, as Dr. Shoumitra and Dr. Diti would have talked about. And we know that it's the function of the glomerular filtration barrier to ensure that the protein is not lost. So let's look at the structure and function. Then we'll talk mainly about 3 important diseases which are associated with nephrotic syndrome, namely minimal change disease, membranous nephropathy and FSGS, and what is really the concept of podocytopathy. So, this is a scanning electron micrograph of a glomerulus.
And what you can see is really the surface characteristics here, and if you look carefully, what these interdigitating processes are really the foot processes which come down from the visceral epithelial cells or the podocytes. So if you remember your normal histology, you have these visceral epithelial cells that are podocytes which are sending down processes, and they form the external surface of the filtration barrier. So this is what it really looks like if you had a SEM view of it. And this is another closer look. So this is actually the cell body, and there would be a nucleus in there, and this podocyte or the visceral epithelial cell, it sends down multiple processes, and we call them primary, secondary and tertiary processes, and then absolute fine interdigitating foot processes, because they look like feet which are basically lying on the glomerular basement membrane. So really when you talk about nephrotic syndrome, the talk is mainly about this cell, which is the podocyte, because it is the one of the most important components of that filtration barrier. So if you look at this little cartoon here, you're going to now see the different layers of the filtration barrier. So you've seen the external surface, which is this visceral epithelial cell. So again, you've got the nucleus, you've got the cell body, and then this is of course two-dimensional, but you've seen a three-dimensional look of how those foot processes come down and interdigitate on the external surface of the GBM. But let's look at it from the other way. Let's look at it from inside out. So you've got your blood in the capillary loop in the glomerulus, and the first layer of the filtration barrier is actually the endothelial. So here you've got the endothelial cell, and it releases these it has these fenestrated cytoplasmic processes which go along the inner surface of the capillary wall, and this fenestra has a diameter of around 70 to 100 nanometer. So that's the first step in the filtration barrier. This is then followed by the glomerular basement membrane, and the GBM basically has three layers. You've got the densa, lamina densa, you've got the lamina rara interna and the lamina rara externa. This is the second layer in the filtration barrier, and then the third is of course the visceral epithelial cells or the podocytes. And you can see that the slit diaphragms between each individual podocyte, and we'll look at some more images of that, that has a much smaller diameter of 20 to 30 nanometer. So that is the basis of the filtration, and that is the basis this structural filtration barrier, as well as there is a charge based filtration barrier, because the GBM and the glycoproteins which are present on the foot processes, they remain anionic. So there is both a filtration, the filtration barrier is both a size and charge dependent filtration barrier, and if you have abnormalities in this filtration barrier, that is what is really going to result in heavy protein loss or nephrotic syndrome. So let's look at it now as in under the transmission electron microscope. Again, you are seeing the three layers of the filtration barrier. Here you've got the endothelial, then you've got the GBM with its three layers, and you can see what the GBM is made of. It is predominantly made up of collagen type 4. Then there are other proteins like laminin, fibronectin, intactin, heparin, sulfate, etc. And you've got the three layers, and then you've got your podocytes. So again, you're now seeing a more two-dimensional view, and they're sitting on the GBM, and between two foot processes is your slit diaphragm. So if we were zoomed in really high power on the transmission electron microscope, you would really see this slit diaphragm, and you can see it there. So it's between two foot processes, and like we talked about, this whole filtration barrier has both a size and charge dependent barrier function with high permeability to water and small solutes, and selective permeability to proteins. Those proteins that are larger would be less permeable, and therefore we do not lose albumin, which is a much larger protein, and those that are more cationic would be more permeable, because as I mentioned, it is an anionic barrier. Okay. So do we not lose any proteins normally in the urine? We do. There is a small amount of protein which is lost in the urine, which is up to 150 milligrams in 24 hours, and that mainly is actually the protein which is secreted from the tubules, which is called the TAM Horsfall protein or uromodulin. And along with that, you may have a very small amount of really small proteins like the beta 2 microglobulins, which can go through the filtration barrier and they're released in the normal individual. But nephrotic syndrome, of course, is very heavy proteinuria, more than 3.5 grams in 24 hours. So you look closely at the slit diaphragm. The slit diaphragm is basically
between the two foot processes, as you can see here, and it is composed of nephrins. So you will have two nephrins, one from each podocyte. This is going to then attach to podocin. So these are the important protein components of the slit diaphragm, and they become very, very important because if there is a mutation, for example in nephrin or podocin, these patients are going to have nephrotic syndrome, and they have a very early age at onset. So just to go through some more names, you have nephrin, podocin, then you have CD2AP. These are three important proteins which are involved in early childhood or even congenital and infantile nephrotic syndrome, and they all connect to the actin cytoskeleton of the podocyte. So now we come to nephrotic syndrome. If you think of causes of nephrotic syndrome, you can divide them into primary glomerular diseases where the problem is limited to the glomeruli, or we can think of systemic diseases which cause nephrotic syndrome. So the primary glomerular diseases include minimal change disease, FSGS, membranous nephropathy, and really MPGN and IgA nephropathy. And systemic diseases, I would put amyloidosis on the top actually. It's a very common cause of nephrotic syndrome. And then also diabetes and some types of SLE can cause nephrotic syndrome. So we are going to mainly focus on the primary glomerular diseases over here. Now this is the first step. So if a patient comes to you and you have clinically assessed that he or she has nephrotic syndrome, you would do a urine sediment examination. What you're looking for is to make sure that there are no other proliferative glomerular features. So you are checking for significant RBCs or presence of RBC cast, which should not be there in just a classic plain nephrotic syndrome, not nephritic, just nephrotic. And what you could find, a positive finding in the urine could be oval fat bodies. So this is what they look like. These are lipid laden bodies, and they are usually from the tubular epithelial cells which are shedding from the kidney, which are quite lipid laden. So that could be an additional evidence. So for us to really think clinically of nephrotic syndrome pure, we want a very clean urine sediment, just heavy proteinuria, no RBCs or significant casts, and then you can find the presence of oval fat bodies there. So let's start with the first entity, that is minimal change disease. So as the name suggests, it's minimal change. So what that means is that the glomeruli look near normal. So if you look at this H&E stain slide, so it's hematoxylin and eosin stain slide, and you look at this glomerulus, it's very normal looking. And how do we check that? We check in all the different parts of the glomerulus. So we look at the mesangium, and the mesangium does not appear hypercellular. We look at the loops, and it doesn't appear that there is any thickening. It doesn't look like there's any proliferation within the loops. And here you can actually see a podocyte right there. So they are visible on light microscopy as well, although we can't really make out the pathology on them. So on light microscopy, this is minimal change. Minimal change disease in most cases is idiopathic, but you should know that there are some secondary causes which may again be associated with a immune dysregulation, and this is association with Hodgkin's lymphoma, rarely NSAID therapy. So as we go through our different stains, in kidney biopsy interpretation, this is a PAS stain which looks more pink, and you see that there is really no abnormality there. And then we have a Jones silver methenamine stain, and on the Jones silver methenamine we check for any changes in the GBM like a reduplication or spike formation in a membranous. Nothing is there. And then you would have a negative immunofluorescence. So very normal looking. So negative, no changes on light microscopy and no changes on immunofluorescence. So how do you make the diagnosis? On electron microscopy, we would see evidence of effacement of foot processes. So I showed you a normal looking transmission electron microscopy, and you really saw these upright foot processes there. And here you are seeing a lot of damage to the foot processes. They are effaced and they appear like they've fallen flat onto the GBM. They are no longer standing upright. There is also a lot of shedding of podocytic fragments with microvillus transformation. So pathogenesis, Dr. Aditi did touch upon this, that we think that there is something in the circulation, some form of cytokine which results in immune dysregulation, and that damages the visceral epithelial cells and causes proteinuria. But even as of now in 2020, we do not know what this circulating factor is. And what is the evidence that this is actually there? It's because of Clinical features that patients tend to relapse in their nephrotic syndrome when they have an upper respiratory tract or viral infection. There is also evidence of recurrence in a transplant patient. So even if you give them a new kidney, they become nephrotic again, which suggests that maybe there is something in the circulation which is hitting the podocytes or visceral epithelial cells. But even now, and the other of course major evidence is good response to steroids. So like 80% of minimal change will respond to steroids, is steroid sensitive. So all that put together suggests to us that there is some form of immune dysfunction or a cytokine which can be suppressed when you give them an empirical immunosuppressant. But what that factor is still not known. Now, the next pathological entity which is associated with nephrotic syndrome is focal segmental glomerulosclerosis. So as the name suggests, focal means some of the glomeruli are involved. We can say less than 50%. So if you had a biopsy with 10 glomeruli, maybe you would see 2 glomeruli involved. Then then the next term is segmental. So what does segmental mean? Segmental means part of the glomerulus is involved, not all of it. And again we have a 50% cutoff. So if less than 50% of the glomerulus of a glomerulus is involved, we would say segmental. And then sclerosis. So this is what you really see under the microscope. You see that a part of this glomerulus is now looking like it is collagenized or sclerosed, and that is FSGS. So like minimal change, it could be idiopathic where we don't know the cause, or it could be secondary, and there are some known causes of FSGS like HIV, heroin abuse, sickle cell disease. Then you could have a secondary FSGS in patients who are obese or hypertensive, and then there is actually a third variety which is now coming up, which is the genetic cause of FSGS. So these would be the three types of or the three causes of FSGS. This is another histopath image. So again here you are seeing the segmental sclerosis, and it's associated with some hyaline accumulation, which is basically just insulated plasma proteins. And this is on the same lesion on the silver methenamine. So again you are seeing this really closed up sclerotic segment, and there is presence of peripheral hyaline accumulation, and the rest of the glomerulus looks absolutely fine. So we do an immunofluorescence on this case. The immunofluorescence will again generally be negative. So if you think about your glomerular diseases which are very IF positive, we talk about lupus, full of immunoglobulins. It's an immune complex mediated disease. But minimal change and FSGS are not. So they will have a negative immunofluorescence. And if you do the EM, this is actually the same picture from the minimal change, because they look the same. Usually if you've got an FSGS which is your idiopathic or primary FSGS, you cannot differentiate it based on electron microscopy. On the other hand, if you have a secondary FSGS like in an obese patient or hypertensive patient, in that case the food process effacement tends to be a little more tends to be a little less, so it's not so widespread, and that in recent literature is now being described as a way to differentiate primary and secondary FSGS. So FSGS is actually not a diagnosis on its own. It is a morphological manifestation of a variety of insults. Like I showed you, it could be genetic or it could be adaptive. Excuse me. On immunofluorescence, it will have negative or minimal mesangial IgM and C3 and a lot of non-specific deposits in the sclerotic segments, but no significant immunofluorescence. And on electron microscopy, you would have variable podocyte effacement. If you are looking at a primary idiopathic FSGS, you will get diffuse food process effacement, but if it is a secondary FSGS, it could be a more focal food process effacement. Now once we have made a diagnosis of FSGS, we try to give an idea of its location within the glomerulus, which is known as the Columbia classification, and I will just touch upon it. There are 4 variants. There is perihilar, so it would be perihilar around the hilum tip, which is absolutely opposite the hilum at the tubular pole, collapsing because it looks like a collapse, and there is extensive podocytic hyperplasia around the fragment which is sclerosed, around the segment which is sclerosed, and then you could have a cellular variant. So all you need to know is that if you say collapsing variant of FSGS, it has the worst prognosis. So there is a morphological correlation between the look of the FSGS and the prognosis, whereas the tip lesions behave very well. So this is what we really mean by collapsing variant. Is it sclerotic? Yes, but the additional finding is that there is a marked podocytic hyperplasia over it, and in these patients they do badly, and we always then advise the nephrologist to check for certain conditions which are known to cause a collapsing phenotype, such as an HIV infection can cause it, a parvovirus B infection can cause it. In current times, a COVID-19 infection is known to, in case reports, to show collapsing variant of FSGS. So this is also FSGS. It has a specific look to it, and it has certain specific etiologies. And in African Americans, really, I mean, not in our part of the world, but in African Americans, there is a genetic basis which is the APOL1. This is what a tip variant looks like. And in the tip variant, like I said, it's opposite the hilum. These patients tend to do really well, and they nearly behave as well as a minimal change disease. They may even show some steroid responsiveness. But you must remember, like Dr. Aditi had mentioned, we do not biopsy patients who are steroid sensitive. Okay, so whatever morphology or pathology we are looking at is on biopsies of children who are steroid resistant. They are already resistant. What is happening in the sensitive is we only know this from very early literature from the 1960s and 1970s of what those biopsies showed, because very soon it was clear that these children who are sensitive do not need a biopsy. So we don't see those pathologies anymore. So you are much more likely to find an FSGS now than you are likely to find a minimal change. It's just because it's the biopsy practice, right? Whereas in adults, the biopsy practice for nephrotic syndrome is you empirically do not give them steroids, you would biopsy first. Okay, so this Kaplan-Meier shows us that the tip variants, they do very well, whereas the collapsing variants do badly. So why does primary FSGS happen? So we basically think of minimal change in primary FSGS as one thing. We again think that there is some circulating factor that is damaging the visceral epithelial cell, and so there are schools of thought that dividing a patient into a minimal change or an FSGS is not so useful. What it is basically it is a podocytopathy. So it is a disease of the podocyte, and as of now we think it is a circulating cytokine which is causing that disease. So some people like to just put it under the bracket of podocytopathy. Now I am going to touch upon the third cause of FSGS which I talked about, which is genetic, and the chances of finding a genetic cause in FSGS are much more in much younger children. So we talked about nephrin, which is the primary component of the slit diaphragm. A nephrin loss associated with the mutation in the nephrin gene, which is NPHS1, is known to cause a congenital nephrotic syndrome, which is called a Finnish type, because that's the population where it was first found in. So this means that the child will present either in utero with nephrotic syndrome or within 3 months of birth with nephrotic syndrome. The second one in childhood FSGS is podocin. So this again makes sense. So it's with the two nephrins, and then you've got the two podocins on the slit diaphragm. These patients are also usually very young. A third very important genetic cause is WT1 mutation, which is known to cause another type of sclerosis. It's called diffuse mesangial sclerosis, and it can be seen in syndromic association. And the syndrome of WT1 mutation, one very important one, is the Dennis-Trash syndrome, one of many. If you look at adult FSGS, the genetic basis for adult FSGS, we talked about a particular type which was the collapsing FSGS, in which APOL1 is an important cause, but again it's not really been found in Indian population. It's more of an African American genetic issue. So I mean, can adult FSGS can there be other than APOL1? Yes, there are a lot of other proteins which are and they've been mutations have been found in them, and they're responsible for adult FSGS. But the profile of the genetic mutations between childhood and adult FSGS are different. So you expect nephrin, podocin, maybe CD2AP, WT1. These are the mutations causing childhood FSGS. Whereas in adults you look at different. So there are other genes of particularly the actin cytoskeleton and different channels in the podocyte, like a TRPC6. So there are different genetic. Both of them do have a genetic basis, different genes and different percentages in different percentages. So what does a congenital nephrotic syndrome look like? Very non-specific glomerular histology. It will just look like an FSGS, like you can see here. But you will see marked damage. So these kidneys will not survive. Patients will have severe nephrotic syndrome. And if you did an EM, you'd see the same thing. you would see extensive effacement of the foot processes. This is the morphology of diffuse mesangial sclerosis. It looks different. They are called yarn balls. So, it is not like a segmental sclerosis involving part of the glomerulus, the whole mesangium tends to get sclerosed, and the best association is with WT1. Right, so that is all that I had about FSGS. Now, I am moving on to the next entity, which is membranous nephropathy. So, membranous nephropathy used to be considered idiopathic in 85% of cases, but there is a major update in the recent past, and we will talk about it. And then there could be a number of secondary causes. Important ones are gold, NSAIDs in drugs, malignancies. So, if a patient has nephrotic syndrome and a solid organ malignancy, the most common pathology found is membranous nephropathy, such as with carcinoma lung, colon, melanoma, etc. Then you could have a lupus membranous nephropathy with SLE, that is class 5 SLE, and then there are certain infections. So, there is a good chunk of well known secondary causes of membranous nephropathy. And what do you see on histology? You see this uniform membrane thickening, which is why it has got its name. You can see that the capillary walls look very thick compared to what you were seeing on the minimal change patient. Similarly on the PAS. And what is diagnostic is on the silver methenamine, where you see this extensive spiking. You can see the very spiky look along the GBM along with crater formation. So, what do these spikes indicate? This is an oil immersion image, and you can see good spikes. So, what it indicates is basically subepithelial immune deposits. So, this is now immune mediated. You will get a positive immunofluorescence, unlike a minimal change or an FSGS. So, this is the glomerular basement membrane, and in reaction to these subepithelial deposits, it sends, it's kind of remodeling, and it sends these spikes up of GBM material itself, and that is what we see. Now, this is immunofluorescence, and you see a strong granular capillary wall staining with IgG, and you would see its counterpart kappa and lambda. So, it comes with its light chains, and C3 complement would be slightly dim. And when you went into electron microscopy, you would see presence of these subepithelial deposits. So, they look like electron dense deposits, and they are on the epithelial side. As it moves, as it comes, so there is a stage 1 to stage 4. So, as it comes towards stage 2 or 3, you will see very good spike formation. So, this is a case of membranous nephropathy, and you are seeing the subepithelial electron dense deposits, and you are seeing spike formation. So, you are seeing the GBM going upwards forming spikes. So, this is classical membranous nephropathy, and then it tends to resorb with age. So, it looks like a very damaged capillary wall. So, you would have learnt that Hayman's nephritis is the animal model for membranous nephropathy. I do not want to get into this. This would have been discussed in autoimmune. And what is basically happening is that you have immune complexes, and they are going onto the subepithelial side, right, and they are depositing there, and that is damaging the filtration barrier. There is also a lot of secondary podocyte effacement, and that is what is causing the proteinuria. So, along with these antibodies, whenever there is immune complex deposition in any glomerular disease, there will be some level of complement activation, and that complement activation in sublytic doses is also responsible for damaging the podocytes. So, you have all this damage which is happening because of immune complexes which are going on the subepithelial side. So, in 2009 there was a major breakthrough discovery of all in the field of membranous nephropathy in what we used to call idiopathic. So, this is an NAGM paper which basically came out of a group who found the podocytic antigen against which immune complex antibodies were being formed in these patients of membranous nephropathy, and that target antigen in the podocyte was PLA2R, which is phospholipase A2 receptor. So, this was actually the target antigen against which antibodies were coming, and they were shedding and forming these subepithelial immune complexes. So, that is why the immune complexes are in a subepithelial location. It is because the target antigen is the podocyte, and the podocyte is of course on the epithelial side. So, that is why you have all these immune complexes there. So, PLA2R is part of the normal glomerulus, and it is a normal podocytic antigen, but what is hypothesized is that there is a conformational change which makes it an autoantigen, and it elicits then an immune response and results in membranous nephropathy. So I don't want to go into too much detail of this, but this is from the original papers where they showed co-localization of the IgG of the membranous nephropathy with the PLA2R. So you can see this confocal co-localized image of membranous nephropathy. So this is just a list of all the other secondary causes. So in the primary or idiopathic membranous nephropathy, the biggest breakthrough was PLA2R, although now there are a lot of other podocytic antigens that are now coming up. So it seems like membranous nephropathy may look the same to us, but its pathogenesis is very heterogeneous. It may be stimulated by different autoantigens, and then this is the list of the secondary causes. Right, so this is my last slide, just to show you how things have changed if you look at percentages from just childhood nephrotic syndrome. So you've got your list of diagnosis which pretty much remain the same as we have discussed. You've got minimal change disease, FSGS, MPGN, which we discussed with you in glomerulonephritis. So we have not talked about it here today. And then membranous nephropathy. So you see that there was a lot of minimal change disease in the early years, in the 60s, early 70s, because of biopsy practice. But as we go along, this is 2003, and you see that there is nearly equal amounts, or actually even more, FSGS. So this is in a pediatric population, of course. Right. So that's it from my side. That's the pathology of nephrotic syndrome. So we basically looked at the three major lesions, and we've talked a little bit. We started off by talking a little bit about the filtration barrier. So the why, and then the three different lesions. Thank you.
এটা লাইন আর বলছি এই দেখো হ্যাঁ একটু আগে কথা বলবো এই দেখো না তাহলে রাখো না Follow the